Hey everyone, good evening on the West Coast. It's another exciting American Head and Neck Society TORS webinar. My name is Chris Holsinger. I'm a head and neck surgeon at Stanford, and it's a real pleasure to be introducing Dr. Megan Turner and Dr. David Cognetti, who are our superstar moderators for this evening's webinar, optimizing outcomes and managing complications. They're going to introduce our panelists, but I just want to thank the American Head and Neck Society, especially Ochin and Melody, Colleen, and our sponsors, Intuitive Surgical, for allowing this to happen so consistently. I've been amazed at the exchange that these generate, not only in the webinar, but afterwards as well. And I look forward to a great conversation tonight. With that, I'm going to fade to black and hand it over to Megan and Dave. Thank you all very much.
Chris, thank you. This is fantastic. It's been just awesome to partner with Megan on this and welcome three outstanding panelists. So we have Jeremy Richmond from Harvard Mass Eye and Ear. We have Heather Starmer from Stanford, and we have Michael Toff from Vanderbilt University. Megan prepared these slides tonight and is going to help guide us through some interesting cases, some complications to think about, and a great discussion with our panelists. So go ahead, Megan.
Great. All right. Well, so this is us. There is a quick plug just for participating in the AHNS and becoming a member. All the fellows, residents, you should become a member. It allows you to apply for grants and on and on. So tonight's learning objectives, we have first to discuss the life-threatening complications of TORS. Secondly, to understand the management so as to prevent mortality and long-term morbidity. And then thirdly, perform some sort of root cause analysis of each of these cases to identify factors that might prevent such complications for future patients and have us thinking ahead. So with that, I think we were going to have an audience poll.
Yeah.
How many TORS cases?
Get a sense of the experience of the audience. So Ochin, you can probably close it at this point, and hopefully we can all see the results, or maybe you can display it for us. There it is. All right, so we have a broad experience level, which leads nicely, look at that breakdown. Oh, it's interesting, it's a true bell curve. So it leads nicely into the discussion of learning curve.
Yeah, so the TORS learning curve has been studied since the beginning, really, and Gendon was the first to look at this, and they found over at Mount Sinai that approximately 18 cases were needed to really cut down on the setup time, and that 20 to 40 cases were required for the operation and resection times. And you know, I would posit that that actually should be looked at for every single TORS procedure. You know, a TORS oropharyngectomy is not the same as a supraglottic laryngectomy. Albergati et al. From Pittsburgh looked at how many cases you needed to hit the learning curve for positive margins, and the inflection point there was about 30 cases, and that informed our surgeon credentialing. Here's that first figure from Gendon that shows the setup times at about 18. Here's inflection points with surgeon A having 27 cases, surgeon C 25. And then it's actually quite a longer learning curve when it comes to complications. So White and Magnuson in 2014 looked at their series, and approximately 120 cases were really required for bleeding and other rare complications. And the biggest drop came after the first 40 cases, which you can see in group 2. But then there was an increase in complications. And then in that paper, they supposed that it was because they were taking on more complex cases, larger tumors in that third group. And so naturally, you would expect that you might also have a bump in complications. Looking at an institutional learning curve, this is a great study from Memorial Sloan Kettering, first author Ashley Hay, looking at their complications overall. And in this data set, they really looked at complications specific to TORS, and then complications that were just related to their hospital course and the operation, and non-TORS complications, for example, neck hematoma or neck infection. And as you can see, they cut down over the first 5 years of their study. So at this point, we're going to go to our panelists.
Yeah, so we have a nice level difference of experience, if you will, on the panel, in that Jeremy trained, I won't guess how old you are, Jeremy, but I know that you did not have TORS training during your fellowship, whereas Michael, a few years younger, trained and had TORS experience in residency and fellowship. And when you look at the dates of these papers, the Gendon paper was before FDA approval, so that was clearly not a fellowship training issue, and some of the 3311 stuff was after TORS was well up and running. So it'd be interesting to hear differences in learning curves in practices when you've had some training in fellowship versus not. Jeremy, do you want to talk about your experience?
Yeah, well, I think, something to keep in mind is that those studies that you showed were all at high volume institutions with, all-star surgeons. And so that is difficult to extrapolate to, for lack of a better term, the common TORS surgeon who may be, doing 20 cases a year, which is high. So, it's not only about the numbers, but it's about the velocity, how quickly you're approaching that learning curve. If you do 5 cases within 2 months, that's very different than 5 cases over an entire year where you kind of have to reinvent the wheel each time. But I mean, that really gets to, my early experience. I started before FDA approval, so it was kind of all off line at that time. There was no formal training pathway, and I had to start really relatively slowly with very selectively cold cases to make sure that it was going to be successful. I also came in with some experience with TLMS, right? And so that really translates quite well to TORS. So for those residents that have an active laser laryngology experience, it's going to be much easier to pick up TORS than if you're starting this from scratch. But in general, and I'll pass it over to Mike here, most of our TORS or our AHNS fellowships now offer very active TORS programs where the average fellow, I think, gets a very good experience within their year. And Mike, maybe I'll transfer it to you now.
Yeah, thanks, Jeremy. I'd like to highlight the TORS curriculum, which is a fantastic resource through the American Head and Neck Society, supported by Intuitive Surgical. This includes lectures as well as a hands-on cadaver course in Atlanta, where fellows have the opportunity to learn from other TORS surgeons across the country and learn different tips and tricks. And the other thing I really liked about the curriculum was the emphasis on patient selection and setup, which I think are probably the two most, arguably the two most important things in oral surgical management of oropharynx cancer. And then finally, the opportunity for the TORS certificate through the American Head and Neck Society, I found that helpful when applying for credentialing and at my institution and the robotics committee. So I very much benefited from fellowship level TORS education through the American Head and Neck Society.
So actually, maybe I'm just going to take a quick second here and put in a plug for the Montreal course, because, as part of the course that the AHNS has put together here for the fellows over the last few years, there's both the hands-on kind of cadaveric part, but also the didactics. And, I contend that the didactics is really absolutely critical for anyone that's going to be starting up in TORS. And that deals with what we're talking about today, how to manage complications, setup, and so on. And we're going to be addressing all of that in a TORS seminar, which is a half-day thing, and that is going to occur on Saturday before the international meeting. Maybe, Chris, at the end of the meeting, you can come back and circle back and give us some information, because that's going to be open for everyone.
I have a question for Heather Starmer on this one, just because I think, like, if you're in a institution with a kind of well-formed program, you might have a mentor, someone who's established before you join. The role of the speech and language pathologist at the institution and really helping you select your first patients, or steering you away from patients who might have trouble afterwards. I imagine Heather has strong opinions there.
Yeah, absolutely. I think it's kind of interesting because when we're talking about the learning curve in terms of the surgical piece, I think we've also, as a community, had quite a learning curve in terms of how we think about the functional outcomes. We started off really just looking at surrogate measures and looking at peg dependence, and we've learned to be a little bit more discrete in terms of how we're measuring these functional outcomes. But I think absolutely that piece about choosing the right patients to do this procedure is very important. And we've come to understand that baseline swallowing status is highly correlated with functional status after TORS. And so I think partnering with a speech language pathologist who can do that instrumental evaluation, looking at baseline functional status, is really important. And thinking about the implications sort of with swallowing across the spectrum. So knowing that it's not just one thing or another, that this is a wide range of different procedures that we're talking about. And so really working together to talk through what exactly the procedure will be and whether the patient is equipped to recover from that.
Great comments. Jeremy, I like the fact that you differentiated 5 cases in a short time frame versus 5 cases over a long time frame, because I think the concentration matters. I also did not have TORS training in my fellowship, and when I first trained with Intuitive, they were pretty adamant that you have cases set up so that after you're done with your training, you go right back out and you get to start and do hands-on stuff. And I mention this because I think about 25% of the people on the poll don't do TORS currently. That's very helpful. The other thing I found helpful is once you get a handful of cases under your belts to then go do a course. Because if you do the course with 0 experience, you don't even know the questions to ask. You don't know the things you don't know to fine tune. So it's very helpful to stage that education. And so people who are planning that out for this summer, that course that was mentioned before would be very valuable. Heather, you made great points about patient selection. So I would love to hear from all of you, as your experience grew, how has your selection changed? Or maybe some tips on selection.
I mean, I can comment from a functional perspective. I'm sure the things I'm looking at are very different from what Jeremy and Mike are looking at. But there was a really nice study that came out of Emory. Lauren Ottenstein headed up not that long ago. And there were particular aspects of the pharyngeal swallow that tended to correlate more highly with dysphagia following surgery. So those are things like baseline pharyngeal contraction, whether or not the patient had timely swallow onset, whether or not they had good pharyngeal clearance or residue in the pharynx. So those are things that we can think about when we're doing our baseline assessment with patients. But one of the other big pieces that I think about and talk about with the surgeons quite a bit is soft palate involvement. I would say that the most devastating outcomes, functional outcomes I've seen with patients have been related to soft palate resection. And so that's another big piece that I'm looking at from a functional perspective.
I mean, I'll just say that, the selection of the appropriate TORS patient is a team sport. And so this is something that, for some of those out there may know that Heather and I started this together when we were at Hopkins, and we were introducing a novel technology in an institution that historically was not super enthusiastic about surgery for oropharyngeal cancer. And so we were really swimming upstream, and it was really the swallow functions and having Heather and her team involved that made it the argument so compelling that it was hard to ignore, that these patients were getting through and their swallow outcomes were such. It was just a different beast than what we were seeing with chemoradiation. So, my big takeaway, and Heather beat this into me years and years ago, and I still carry the same mallet that she hit me with, is that SLP needs to be involved with all of these patients before you choose, before you make the decision that they have surgery. They should all have functional assessments beforehand and afterwards. And if you don't, then it's going to be really hard to demonstrate one, objectively how well they're doing, and two, have the data to convince the rest of your team members that this is the right thing to do for the properly chosen patient.
There is one question in the chat. Are there any courses or lectures available for non-fellows or postgraduates? Is that course this summer open to non-fellows, Jeremy?
Yes, yeah, it is. Also, we have a library of all these videos that we've done for the AHNS course, and I'll have to see if they're up on the AHNS website. But that's one thing that should be available for AHNS members. So I'll follow up on that, but it should be available for everyone here.
Great.
Mike, what about your the AAO course? Is that something that would be open to just members of AAO?
Yeah, we're thanks, Megan. We're going to be having a pre-academy AAO course as a host institution Vanderbilt in Nashville, Tennessee this fall. And a big part of the curriculum will be transoral robotic surgery and lectures related to that. Won't be any hands-on dissection, but that is most definitely open to the community. And please reach out and look out for flyers related to that.
All right, shall we proceed? Well, so, and this is sort of touching on some of those arguments earlier about kind of the frequency with which you do cases. This was a recent publication in Cancer by a mixed group, including NYU, and you can see Neil Gross and Uma DeBury are on there, as well as Luke Morris from MSK. And they were looking basically to see if there was some sort of cutoff at which there was more complications or not, or the mortality rate changed. And it does seem to be about 10 cases a year. And, you know, I think that sort of speaks for itself. If you're doing 10 cases a year, you're doing about a case a month, assuming you actually go on vacation and are a normal human, right? And not a robot yourself. So, you know, kind of makes sense. So, you know, I'm going to present some of the complications that I've had as a jumping off point. And this is a patient who's near and dear to my heart. He came to me with a neck mass, and on laryngoscopy, he had this sort of superficial but centrally based base of tongue mass. He had a unilateral neck mass that he noticed, but as you can see, there's a suspicious round node on the other side that's not highlighted. And he was young. He's 56 with grandkids, very functional guy, owned his own business, actually in construction work. And so he was hoping to avoid adjuvant therapy. But we sort of talked about that would not be the goal for him. It would be reducing the overall dose because upfront he needs bilateral treatment of his necks. I proceeded with this because I thought, well, this is a superficial cancer. I think I can safely get negative margins. Little did I know I was going for big margins. This was early in my institution's learning curve, right? And early in the experience. And I did not want people saying, you can't get negative margins with TORS. It's just a biopsy, right? And so I went for widely clear margins. And while I was doing so, I clipped both lingual arteries. I got the tumor out. I proceeded to the neck dissection. As I was closing up the neck, I looked over at the mouth and noticed the tongue was white, and set up the machine again, got back in there, saw that I had placed a clip very lateral on the other side of the tongue, even though I didn't really have, you know, bad bleeding on the other side. And so I got spooked at this point, and I did not do transcervical arterial ligation, because I thought, oh my gosh, what if he only has collaterals from his facial branches on that side? I actually took clips on and off and replaced them so that I could get perfusion to the tongue, had perfusion to the tongue. And I thought, well, I can deal with bleeding, but I can't deal with a dead tongue. So I will show you, I went back and I watched this over and over again. I end up having a bleed on post-op day 2 from the right side. And you can see there's the clip, there's the vessel on the ipsilateral side. And then you can see this here. Here's the injury on the left, just a slow frame there. This is a big specimen, but this clip is placed below the burn. It's proximal. I didn't get it like distal as well. And that was an error. And then clips were placed on and off around this burn. So he bled. I left him intubated for the first 24 hours just to see if by gagging or being lightly sedated, we might have a bleeding problem. Day 4, he bled. He was not protecting his airway. We did a bedside trach. I took him immediately to the operating room because he did aspirate blood significantly in front of me before I got the trach in. So I wanted to make sure that I got all that blood out of his lower tracheobronchial tree and didn't get pneumonia. Because in fellowship, having seen a patient expire from the pneumonitis 7 days later, I didn't want that happening. So I went and bronched him right away. I did a CTA immediately after I found no source of bleeding in the operating room. I looked, we did Valsalvas. I was rough in there, couldn't recreate the bleeding, did the CTA and thought that is extravasation, and went back in actually thinking I need to find that or put a clip on. Couldn't find it. I tried to talk to IR. I tried to talk them into doing an angio and embo at this point in time. They would not do it. Even with that first CT on the right there. This was the repeat CTA on day 8, and you can see this large aneurysm here. And at this point, they still would not take him back. They wanted to let him bleed again. And I had to get on, the phone on a weekend and say, listen, you can't let this happen. And so they went back and embolized him, and he survived. But 4 days passed where he was seemingly fine. This could have been missed, and he might have bled and died in spite of the fact that he was trached, right? He is actually 3 years out this past January, and he's doing quite well. This was his embolization. You can see the angio here, huge blush. And then this is post-embolization on the right. He still talks to me, and in fact, he let me operate on his nephew, which is incredible to me. I mean, that just shows you how much our patients trust us. When I look at this, I say going for a big margin was the worst thing I could have done there. That's what got me into the other side and had me clip the other side, and even get close. And I'm sure I just got a small branch, but I was overly zealous. That had me spooked, which means I didn't ligate vessels, went away from the typical teaching and practice. I don't know that ligation would have prevented this, because it was actual arterial wall injury and distal to where the clips were, right? But really, I look at this as it was a technical error of injuring that vessel, burning it, putting clips on and off around it, and then not having the backup. And perhaps I should have just trached him given that whole scenario, right? Because I didn't ligate. I've certainly done that since in people that I couldn't ligate or didn't ligate. So things to avoid in the future. We know that ligation of the arteries saves lives from the ECOG trial. There's very little downside to it. This nice study by Top over there. No, he can talk about this, just showing that first bite is really the only thing you have to worry about.
Okay, do you mind if I make a comment about that, Megan? So,
Please.
you know, I think this, yeah, this is a really good, you know, lesson really that goes back to patient selection, right? So, like, I'm not going to be critical of you choosing to operate on this patient, but certainly for someone early in their experience, there's a few things that should raise a red flag. And so one would be, at least in our experience, every institution has, you know, somewhat different laws, I guess, that they would operate by for patients with HPV associated disease. And so one of the things that we would steer away from is for bilateral neck adenopathy, or for tumors that are clearly involving the contralateral side of the tongue, because those patients obviously have more advanced disease, and you're talking about doing a big surgery. And chemoradiation in the grand scheme of things may actually have better functional outcomes than a bilateral neck dissection and central base of tongue resection. So I'm not saying that it's the wrong answer, because sometimes we have to do it. You know, I've done this for patients that can't get chemo for whatever reason. And in those scenarios, I always stage the necks. Because I think doing bilaterals and a big whack in the base of tongue is just too much on the patient. And it allows you to get the ipsilateral pathology, which sometimes will show you that there's gross ECE. And in that case, there's no point in doing the contralateral neck. You know they need chemorads. So I think if you have a patient such as this, and you're going to do bilateral necks, stage it, take it slow, because it's a big hit on the patient. But for those people starting out, this is one of those cases that should give you pause and probably hold off on.
And he ended up having ECE. So he ended up getting chemorads, and he had his PEG for, I want to say 3 months. He did push through it, right? I didn't save him a thing. And
Megan,
I almost killed him.
Yeah, and Megan, I'm just moderating the chat here. And as I pose this question to you live, I actually want to, we have a question from Alice Lynn. Hi, Alice. What was the stage of this patient, and was there adjuvant treatment? Before you answer that, Megan, I actually want to compliment you for having the courage and also the forthright nature to talk about these things. We don't do this enough. And I'm inspired by your courage to do this, because I don't know who said this, like, good judgment comes from experience, and only experience comes from bad judgment. We need to share these lessons with one another, from the lesser experience to the more experience. I just want to compliment you as I hand off that question about the staging.
Yeah, Chris, I think the famous comedian Stephen Wright says experience is a thing you get right after you need it. All right, so Megan, yeah, what a tremendous case to share. And I would say, yes, in hindsight, there should be a lot of pause in this. But even with pause, there are features on that scan that could say, hey, this is reasonable to operate on. Low volume neck disease, low volume primary, crosses midline but superficially. I would have predicted that the lingual arteries would have been in play on both sides. And so if it's superficial crossing the midline and low volume, you could reasonably expect radiation alone, potential help to this patient, etc. So it's not a slam dunk, never do it. But as Jeremy said, to those people who are starting off, these are not your early learning curve cases, and should give you pause, because the risk benefit ratio becomes a lot tighter. And maybe Heather can talk about that a bit in terms of base of tongue and location of base of tongue and depth and other things that might impact the expectation for functional outcome.
Absolutely. I think we've learned over the past couple of decades that the depth and the crossing midline are both really important factors in terms of the functional outcomes. So if we're doing a really deep resection, you end up with this quite large divot that the patient really just can't sort of overcome. And particularly if that crosses over the midline, because then you're not getting the contralateral side even able to compensate for it. So I think, we know generally speaking, with some exceptions, that base of tongue patients generally do a little bit worse than tonsil patients from a swallowing perspective. And I think those two things are the really big things we need to be thinking about is depth of ovation and crossing over to midline. And I think the other piece that comes in with that as well is from a neck perspective. And when we're looking at that bilateral neck dissection, we're also then looking at a much higher potential burden from lymphedema. And we're also starting to understand a lot more about how much lymphedema is feeding into these dysphagia issues as well. So I think all of those things together are really important considerations.
So one thing too on pathology, I forgot to mention, he actually had multiple primaries. So he had a little T1 that was like 8 millimeters in the tonsil on that ipsilateral side. And then the base of tongue, I believe was called T3, just because it abutted the lingual surface, and I took off that, the mucosa of the, epiglottis, the lingual surface of the epiglottis. And I believe that other node was in fact positive. We doubted it, but you can see it's fairly round. So, and he had ECS, like I mentioned. So he got chemo, he got RT, he had the PEG. The trach set him back too for swallowing, right? That trach from bleeding really, it stops their elevation, their hyolaryngeal elevation. He until I took that out, he really didn't even begin to try to swallow and rehabilitate, and then he got hit again while he did eat before radiation. He stopped completely and needed his PEG during radiation. So, and he kept it for 3 months, and his weight, was an issue.
And I think that's another really good point is that we have a really small period of time between surgery and radiation that we need to really be functionally optimizing patients to the best of our ability. And so being really aggressive with the rehabilitation post-op so that we can get them eating and get them as close to normal as possible before radiation is ideal.
Megan, a couple points. The multifocal primary in HPV-mediated disease, I think, is probably a little more common than we think. And I know this is a area of interest and research for Dr. Holzinger, so I'd let him comment on that. To piggyback on Jeremy's comments on patient selection, I think when you look at ECOG 3311, there's a lot of data you can extract from that trial to help with patient selection. This patient was N1, but patients on ECOG 3311 that had clinical N2B disease based on the 7th edition were 45% of them wound up in RMD and got triple modality therapy. So now as a more junior TORS surgeon, whenever I see a patient with 2 or more lymph nodes, I always pause and seriously consider whether I want to offer that patient surgery.
And not only whether you want to offer it, right, but certainly that they understand that you're not going to spare them radiation. They don't even have a shot at no radiation. It's 100%, that they're going to get radiation, right? It's what is their goal? Or like previously mentioned, maybe they can't have chemotherapy, right? And that's the reason why you're trying to escalate with surgery, but there have to be reasons. Yeah.
All right, I think we have another question now.
Yeah.
So as the answers are, as many of you have done Zoom webinars know, sometimes it's hard to monitor the chat and actually run the webinar. So I'm serving the function as the chat monitor. And so Dave and Megan, we have one other question from Varun Vendra. Hey, Varun. How long would you wait to decannulate a patient with a bleed and no clear source identified? Maybe I'm interrupting your poll, but I thought I'd get that question we haven't answered up to our moderators to handle.
Let's close the poll and see the answer to this poll question, and then maybe we can answer the chat question. So 86% say yes. Why don't we do the next question as well, Ochun? So we can close this. Megan, do you want to advance the slide?
Oh, yes, indeed. Sorry. There you go.
So for the 86% who said yes, this poll question should allow you to select multiple of which vessels you typically ligate. Yes means branches. Yeah, yeah, the poll's already closed, but yes meant branches of the, yes, sorry. We did not go to question writing class for this. And we fully recognize that there are scenarios and maybe depending on the primary site, depending on what was encountered. So just try to answer what you typically do most routinely. Is the poll up? Were you able to open the poll? So while we're waiting, we'll see if this poll comes up, but while we're waiting, why don't we talk about the question about the decannulation. So in this situation, you had a high suspicion for arterial bleed, and you weighted that out with multiple imaging. And the question was, if there's no source of bleeding identified, when or how comfortable would you have been with decannulation?
Well, I think so, an early bleed is arterial, right? It's a technical error because you shouldn't be having like the tiny tonsillectomy type bleeding unless there's an event like, vomiting or something and it stops and it was minor, right? But typically that's not your early bleed, first couple of days. I think if it's a late bleed, like day 8 or day 10, and it's minor, well, that's a no-brainer. You don't really have to worry. But in this instance, I would wait the full 2 weeks, right? And just they have to be fully healed and mucosalized. And then I might even consider another angio. I don't know if anybody knows the answer to that. I mean, what?
Yeah, so Megan, I know Chris is monitoring the chat. I'll just say there's a lot of comments in the chat complimenting you for sharing this case. And I will compliment you for how you managed, once you secured this patient's airway, you also kept the patient in the hospital because of your high concern for arterial bleed. And you were persistent to identify the pseudoaneurysm, which ultimately saved this guy's life. So my answer to, if you've made the decision to put a trach in, there's no rush to take it out until you're really sure you have the life-threatening issue covered, if you will. Your ultimate goal obviously would be to get the patient decannulated before adjuvant therapy if indicated, but other than that, there's no rush to take it out. Since we're having issue with the poll, Jeremy, why don't we start with you? Can you make some comments on what goes into your decision-making on vessel ligation and which vessels?
I keep it as simple as possible. I do lingual and facial for essentially every case. I rarely deviate, but sometimes I'm not there. I don't want the residents to try and guess what I want ligated, just lingual and facial every case. I will say, however, I am a true believer of first bite syndrome, thanks to your paper there. And we do try and do minimal dissection because I've seen it a lot in patients, and you don't appreciate it to 3 or 4 months afterwards, and then you get to blame it on your rad onc. But it is true, like if you do too much dissection along that carotid, they will come back with first bite.
Michael, maybe, and Megan, go to the next slide, if you will.
Sure.
Michael, your comments?
I agree with Jeremy. If it were a well confined to the tonsil, sometimes I hold off on the lingual, but if it's an inferior tonsil or, lateral tongue base, then lingual facial.
I
do
think
you-
the only reason to add superior thyroid is if you have, one that forces you to do supraglottic laryngectomy, right? And it's that branch that comes kind of off from the paraglottic space up, near the lateral glossoepiglottic fold. That'd be the only reason to do superior thyroid. Certainly I've done that, but it's in somebody who also got supraglottic laryngectomy.
So I agree with the comments already said. I'm definitely a simple guy as well. Lingual facial every case. It's sometimes extended, as you said, to the superior thyroid, but by and large, it's just lingual facial every case. If you do have the picture of the carotid artery.
Oh, I can go back. Yeah, let's see. There you go.
No, do you have the live picture from the OR or not?
Oh, sure,
In one of the
sure.
Pictures I sent you. If not, it's no big deal.
Oh, no, I don't have that one. I apologize. Yeah, I
No,
don't.
it's okay. What I was going to point out on the picture is, after that first bite paper, we learned a couple things. Number one is if you chase the ascending pharyngeal, you're more likely to have first bite. And number two is you can actually see the sympathetic branches running up the carotid. And it's not very difficult to take your right angle or other instrument and loop under that sympathetic branch and just get the artery and pull a suture through. So things to think about.
All right. So just about bleeding, we know that the death due to hemorrhage rate is actually very low when ligation is used, and it's 0.6%. If you look at whether or not ligating the vessels actually has any impact on the overall bleeding rate, it does not. That shows you there's a relative risk of 0.94. That's what that's the overall bleeding that's akin to tonsillectomy bleed, that post-op day 8, post-op day 10 bleeding that people come in with. It might need to go back to the OR, but is not life-threatening. The major hemorrhage rate where it says they're spitting up blood, they're not protecting their airway. That's lower. It's 2.9%. And in those cases, we only found a trend, but 60% reduction, I would argue, is clinically significant, even if the statistics don't work out. And there was actually a later systematic review later this year, or later a year ago, by Sharbel, in which they did find statistical significance. And they included one more study with Olivia Lacouré as the first author who found that addition of 2 extra bleeds made it significant. So, I think without a doubt, you should be doing this to prevent people from potentially dying. There are other things that are linked to bleeding. We know that large tumors have 2 times the risk, and anticoagulation, lumped together all types of anticoagulation, and we didn't separate it between Plavix, Lovenox, heparin. You have it. It's just any type of anticoagulation had an increased risk. And then a history of radiation increased the risk of major bleeding. And that's perhaps, you can pontificate about why, but it might just be that it's more difficult to isolate and see the vessels and radiated planes through the mouth, right? It's just more difficult. And then the vessels are more unstable and friable, and maybe more likely to be damaged by spit later. But we would have to really know more. And I think actually the recut study probably tells us a little more about that.
Hey, Megan,
Yeah.
can I ask a question for the panelists? So with that relative risk of 2.25 for anticoagulation, how long are you holding anticoagulation in patients?
I'm at 2 weeks, but
Yeah, I've learned my lesson too many times with anticoagulation. So we talk to their cardiologist and make sure they can be off at least 10 days beforehand if they're on Plavix or something else, and they have to stay off for at least 10 days afterwards. And if they can't, then they don't get surgery.
Yeah, I'm 2 weeks. And same, if they can't, then no surgery.
No, yeah, no surgery.
Yeah, and Michael, your paper showed Plavix is a bad one. Plavix, they bleed after Plavix.
4 of 13 patients that were allowed to resume Plavix bled. That was within 10 days, I believe.
Which makes the case for frontline chemo RT. Just a few final comments from the chat. And Ocha and Melody apologize, but the chat, the poll function is not working on Zoom right now. So just heads up for Dave and Megan. But John Pang asks in the Q&A, is an early bleed, quote unquote, truly technical? I know a few surgeons who have had early bleeds in cases that otherwise are very smooth and also clipped both lingual and facial. That's maybe a little bit more of a comment than a question, but I think an important point. And then I also wanted to acknowledge an interesting case from Mihir Patel, who talked about developing a pseudoaneurysm, suggesting an internal division, like Megan showed us in the case, of a terminal branch of the superior thyroid artery. And this patient, Mihir, is reporting bled from a pseudoaneurysm very low in the pharynx. So thank you for reporting that. And then finally, Nader Sadeghi from McGill is talking about, well, hey, how about doing a neoadjuvant approach when you have more than 2 nodes? But that will have to be a topic for another webinar. But I'll hand it back to you all.
I think there are a few really important points, though, for people that are starting out with bleeding. And so I think certainly we all agree that ligation of branches off the ECA is critical. You will have bleeds. You need to be expecting to have bleeds and have your team know how to manage when they get the call that there's a bleed. The vast majority of bleeds are the same thing as like a tonsil, post-tonsil bleed. They're pesky mucosal things, and they look much worse than what they actually are. And patient stories are going to be much more graphic than what they are. I'm not saying that you need to downplay when you get a bleed, but they're saying they're coughing up buckets, and then you get in there and oftentimes you'll just see a tiny little mucosal thing. The majority of these can be managed with a DL or tonsil kit and a suction cautery. And so when your colleague calls you at 2 a.m. and they're on call, you can reassure them, and there's data to support it, that they can manage it with just a suction cautery like they would for any tonsil bleed, unless it's really something that's, out of, a horror movie like Carrie, then it's a different story. But the vast majority of these are really pretty straightforward, and fortunately, relatively rare in our practice now.
I mean, I kind of would think about it. The reason I say, technical error in the first couple of days, I mean, that's what you have when you have a neck hematoma, right? When you have a neck hematoma that bleeds in the pachymeter the first day, it's a clip that came off or that was badly placed, or, vessel that was burned or injured, but maybe didn't bleed right away, so you didn't recognize it. At least I have to think that's what that is for these major bleeds. Sometimes you get it into that parapharyngeal space for a radical tonsil, and it's just it's a spider web in there, right? And if it was a bloody case, you really need to look and make sure all your clips are well placed, and then that you ligate. All right. And so, yeah, so I mean, this is, that's my learning curve data. It looks really high right here, but I only did 4 cases that year, right? And I had a bad bleed, right? But as you keep going and as I get out to 30 cases, I have had very few bleeds. And I think when you're starting out, if you're tracking yourself and you're really wanting to learn and get better, that's what you'll see.
Megan, really nice question from Andrew Holcomb in the chat. For surgeons who treat patients from a broad catchment area, how do you counsel patients from out of town about bleeding? Make them stay in town, work with the outside hospital, something else, nothing? Does this impact patient selection, or does distance not factor in?
Yeah, so I can answer that one a little bit. Number one, I think vessel ligation has significantly decreased life-threatening, life-ending bleeds, right? So It's a little different than the pesky bleeds that Jeremy described. Number two is the patient education is very important. They need to know they can't be doing strenuous activities. And it'll amaze you, some of these patients who want to go back, they're back on their job or something, they're doing heavy lifting. That has to be explicitly forbidden for them, so that they're not doing anything that can promote that. And finally, you really emphasize that you need to be made aware, your office needs to be made aware, and your office needs to know that you need to be made aware of any level of bleeding, so that nobody along that pathway is blowing off what could be a sentinel bleed. So it doesn't weigh in enough for me to say not do a surgery beyond a certain mile distance or hour distance, but it reinforces the importance of patient education and having everybody in your office, whoever answers your phone calls, everybody understanding the significance of what a bleed could be.
I'll say more important than distance is whether they have a companion at home. And so that's the big thing. So, you know, if for us, it doesn't matter really where they live, unless they're international, and then I want them to stay in the country for 10 days. But otherwise, it's that they have to go home with, you know, a spouse or daughter or a friend that is actually in the house with them for the first 10 days after the surgery. And if they don't have that, then it makes me really kind of nervous about operating on them. And, you know, they're not going to have the support to get through chemo rads either. So it's a tough spot.
So what a great discussion. We're chewing up this hour pretty quickly. So Megan, I don't know if you want to highlight the topics and let our panelists give some comments. We just have to be mindful of time.
Yeah, I think this one we can be quick. I mean, so this lady had HPV negative, posterior pharyngeal wall cancer, just sitting like a cute little, you know, nugget visible right through the oropharynx, right, you know, to the level of the soft palate. You can see it here. Looks tiny on the scan, was tiny. But she's kind of unhealthy, diabetes, degenerative disc disease, didn't have any pre-op dysphagia that she mentioned. But I think when we think about this patient, I think the input of our speech and swallow therapist is like critical, because I think you take out both of those constrictors and they swallow terribly. I think this is a bad patient to select. What do you think, Heather?
I would agree with that entirely. And I think a couple of things. One is you say that she didn't mention that she had any trouble. And, you know, we've seen a number of studies have shown somewhere between 25% and 40% of patients who don't think they have any dysphagia at baseline actually do have measurable dysphagia at baseline. So I think part of the lesson is that we have to make sure that we're actually looking and not just looking for patient report. But absolutely, if we lose that ability to generate pressure in the pharynx to drive that bolus down into the esophagus by taking out the constrictors bilaterally, we're absolutely going to have pretty significant issues with dysphagia, residue, and then overflow residue and airway infiltration. So I would agree that that's not the kind of patient that I am enthusiastic about, especially when they're otherwise ill and not robust.
And this lady, her anxiety too, like she was just shaking like a leaf sort of person in the operating room. So she's not somebody who's going to tolerate that, you know, sensation and that anxiety that they all get, you know, when they're first learning to reswallow. To me, that's not somebody you want to choose. Walking them through the next 3 to 4 weeks is just, it's horrible for them. So she was really tough. And then the other thing is she had she ended up needing a cricopharyngeal myotomy because she lost that constriction, then relaxation, that sort of timed effect. And she ultimately did end up swallowing, but I had to follow her through EPIC. She wouldn't come back and follow with us. And she ended up, I think, getting a Cleveland Clinic myotomy and then finally swallowed. So this lady came at post-up day 21. when we were working on swallowing with her intensively and said, "Doc, my neck is hurting again. Like, it's bad." And I'm like, "Well, you shouldn't be having it at this point in time, number one. And number two, did it get better and now it's getting worse again?" Well, yes. She left the office that day, and in my gut, I just had this bad feeling, like I should have admitted her. I called, I said, let's do Levaquin, come to the ER if you get any worse. Well, it was like 4 days later and she was in the ER, altered. Her husband brought her, she was altered. And then I was like, oh my gosh, she's got some sort of meningitis or epidural, something bad is going on. Let's get imaging. That's exactly what she had. You can see her abscess here. You can see her rotten disc space and all the scar against the disc space. And in her case, I wish I had the video. I do not have this video. I distinctly remember skipping off an osteophyte and getting her disc space, going for like the deep margin. To be clear, again, going for wide margins. Hard to get wide margins on a posterior pharyngeal wall tumor. Almost impossible when the patient has osteophytes. This was bad selection. I would never do this again, ever. And, thankfully, this woman didn't die and didn't have neurologic breakdown because I knew about this study, so when she came with those complaints, I was like, oh my God, that's what's going on. And I spoke to the orthopedic surgeon myself and was like, we have to do something. She could end up paralyzed and die because of this study here. So yeah, I would never do this again. Please, nobody do this.
The posterior pharyngeal wall is a tough spot, and it's got to be small and really mobile, because you have to be able to have that clean fascial plane as your margin and not be looking to take deeper than that. So
this was mobile, but I think in her, with all of the degenerative changes, I think that's what would say I would never do this again. Look at all those, look at this fused osteophyte here,
Yeah.
I think if she had a normal spine, yes, maybe if it's mobile, but.
So again, Megan, thank you for sharing this case and being so open about your retrospective analysis on your patient selection. This is helping everybody learn and reflect on our own experiences that we've all had in our learning curve. This is incredibly valuable. We're running out of time. I want to take an opportunity to plug that everybody follow Michael Toff on Twitter, because I've learned a lot just by following Michael Toff, including last week when the news broke that AHN005 was in their interim analysis, the intervention arm, the 60 gray plus cis did not meet non-inferiority criteria. I learned that from Michael. So I want to give Michael a chance to talk about the importance of surgical trials as we look forward to how we apply TORS in the future.
Thanks, Dave. It's at Toff AHNS for those who are wondering. We only have a minute or two, but I do think that as surgeons, we've conducted prospective trials, the ECOG 3311 being the big one, to safely de-escalate patients, and surgeons need to be involved in future de-escalation efforts for our patients, hopefully on trial.
Twitter feed for the top head and neck surgeon in the world. Top. Oh, nice play, Chris. Nice play.
And I would agree with the posterior pharyngeal wall tumors are deceptive. Completely agree with some of the comments that are coming up.
So some comments aren't seen by everybody. They're not seen by the whole audience, but a comment came in that said posterior pharyngeal wall tumors are deceptive. Lots of subclinical spread, difficult case, an important presentation. Great job. Nice presentation. Again, many kudos to Megan, which we all agree with. Chris, do you want to close? Do you have things to talk about for the summer in Montreal?
I will close by congratulating both you and Megan for an absolutely incredible webinar. We need to have more forthright discussions about things that don't go well, because that's how we get good experiences from maybe learning from something we didn't do right the first time. We're going to make it better the next time. And that's what we can do to honor the trust that patients place within us. So again, Megan, I think everyone in the whole world, there are many people dialing in from Europe and from Asia right now, and everybody's been impressed with the example you're setting, and hopefully we'll continue with a similar webinar for future topics like this. Jeremy Richmond and I, as well as Nader Sadeghi, who's also dialing in. Hello, Nader from Montreal. We're excited to again announce a July 8th Saturday course, which is the day before. Thank you, Dave, for this opportunity to do the shameless plug. And wow, right on cue, Megan brings it up. Please come at least a day early, arrive on Friday the 7th and stay for a 6-hour course. There are very few segments of lecture. Everything is a panel discussion or a debate. We're going to cover everything from some of the clinical trials data that Dave and Top were talking about to sort of revisiting things we think we knew about education, simulation, and training. And then we're going to continue to debate it again and again and again about ligation or not, and how and when and what we should be doing for these patients. So we're 1 minute past the hour. It's 5:01 here on the West Coast, and now after 8 p.m. in the East. Thank you all for an amazing webinar, and look forward to the next one.
Great. Thank you,
Thanks, everyone.
Good night. Appreciate it. And thanks, Ochun and Melody, for making this happen from AHNS. Thank you all very much. Virtual and real claps for all. Good night.